Well, that brings us to respiratory failure, and having laid the groundwork, I think I think this will be a more meaningful talk. And this has certainly been a topic of a lot of discussion in the recent months of the pandemic. So let's dive into that one. So we have respiratory failure, which is essentially hypoxic respiratory failure. And the most common reasons would be for example, ARDS or pneumonias, a massive pulmonary embolism, but there, of course, are many. And then there's hypercarbic respiratory failure, which is when a patient can't breathe. That is, that their work of breathing is very high, either because of a COPD flare, status asthmaticus, for example, or they won't breathe because either of a CNS injury or a neuromuscular condition or medications that simply shut down their respiratory drive. I'm only going to say one or two words about non-invasive ventilation, although it's enormously important, so I didn't want to leave it out altogether. In terms of, again, dealing with respiratory failure, from the standpoint of oxygenation, we have high-flow nasal cannula and regular nasal cannulas are up to about 6 liters a minute, and then high flow, which can go up to about 60 liters per minute. It really is an enormously helpful strategy for people who are primarily hypoxic. It's really proven useful in patients with hypoxia due to COVID-19 infections. And it does many things, which I chose not to go into, but among other things, because of the flow in the upper airway, it can decrease dead space. It's more comfortable than I think you can see and imagine that might be true for patients who are on non-invasive ventilation. So really, it's purely for patients who have oxygenation issues, but it can be enormously helpful and by some time without having to do invasive ventilations. And so it really has a role here to play for hypoxic respiratory failure. Non-invasive ventilation is for people who are having trouble ventilating, meaning that their PCO2 is high or they have higher work of breathing. It's non-invasive and therefore has fewer of those kinds of side effects of invasive ventilation. But it has a somewhat defined role, which I will tell you in a moment. It is okay to use non-invasive ventilation for people with respiratory distress, if they have an appropriate diagnosis, which we'll talk about on the next slide, if they have an increased work of breathing, for example, or respiratory acidosis, and there are no contraindications. But the caveat is that it's not really adequate if somebody is unable to protect their airway. There are many patients have trouble fitting the masks, particularly people with beards. If you have an uncooperative patient, it's really not an option. And it really isn't a good support mode for people who are likely to be sick for a long time. So if you don't have a fairly quickly reversible problem, if you have something, for example, like ARDS, where we know that the problems will likely go on for many days, if not weeks, and this really is not the way to manage them. It requires frequent reassessment. So it's best for people who, let's say, are having some increased work of breathing or respiratory rate. You put the mask on them. And if you can see within a relatively short period of time that those parameters have improved, the patient doesn't look like they're working so hard, the respiratory rate's coming down, then you're good. But in the cases where that doesn't happen, and that certainly happens sometimes where people simply aren't supported well with this device, then you should move on. So it really needs to be assessed and reassessed relatively soon to decide if it's working, because we do know that if you delay intubation in people who are not doing well with non-invasive ventilation, then outcomes are actually worse. So it's really most appropriate for people who are having a COPD exacerbation and for people with cardiogenic pulmonary edema, because those are two conditions that can be turned around relatively quickly. In the case of somebody with COPD flare, you can put them on frequent inhalers, nebulizers, steroids, and in several hours, you could really turn them around quite a bit. And similarly, in cardiogenic pulmonary edema, diuretics often work quickly, they can be relieved, and that really can turn them around quickly and they won't need to be intubated. It's also useful for people who are extubated after they've been intubated for a while for some swelling and to try to prevent re-intubation. But beyond that, you can see it has a much more limited role. So, but for those first few, it's enormously useful and certainly data driven. So let's move on to ARDS though, because that really is the paradigm, I would say, of respiratory failure. And you know that ARDS is defined by an insult within a week or so of a patient's becoming ill. It's defined by having opacities bilaterally that are not explained by pleural effusions or nodules or lobar collapse. It's not fully explained by pulmonary edema, cardiogenic shock, for example, or cardiogenic pulmonary edema. And the severity is defined by the ratio of the partial pressure of oxygen to the FiO2. It moves along in some progression like this, where you have some form of insult, whether it's a direct injury to the lung, such as perhaps aspiration or pneumonia, where the injury is directed at the lung itself, but it also can be indirect. And there are many causes of ARDS that are indirect, such as sepsis or pancreatitis, transfusions that are not direct injuries to the lung, but can cause ARDS. So that you have an insult that occurs within several days of the patient becoming sick and symptomatic. You go through a short period where they have hyaline membrane formation. There it is. And then you enter the fibroproliferative phase. And there it is, where you have laying down of scar tissue, although I should say that as bad as that may look, 6 to 12 months after they've recovered, they can look almost back to normal. It can be quite dramatic. The reason I bring this up is because in the last talk I mentioned that mechanical ventilation can actually cause harm. And the way that we mechanically ventilate people can cause overdistension of alveoli, shear forces, what sometimes is referred to as adalect trauma, where these injured alveoli are being forced to open and close without maintaining air in them. So with the loss of their surfactant, this can actually cause quite a bit of stress and injure those vascular and alveolar structures. When that happens, it creates an inflammatory response that can lead to injury of both the alveolar and capillary borders. And we talked a lot about the endothelial injury associated with COVID-19, but that can occur as well in almost any of these injuries. And when that alveolar capillary membrane is injured, regardless of the cause, but including how we do mechanical ventilation, that can lead to ARDS. And we have noticed in years past that there have been patients who started out on mechanical ventilation for other reasons, doing perfectly fine, and then several days later wound up in ARDS. We wonder whether that's because the ventilator itself delivered the injury and caused the harm. And we know that if you that these forces, these structures are quite fragile. We have alveolar capillaries that can be stretched if we are overstretching the alveoli themselves. And again, like I showed you on the last talk, if we cause injury to the capillaries and injury to the alveolar structures, that creates a very significant inflammatory response, indistinguishable from ARDS. So these injured alveolar structures are fragile. What we look to do is maintain them open, and that can take, we have to respect that there is a longer time constant and that it may take a longer inspiratory phase of ventilation to keep them open. And that's partly where we're going now with this talk, which is how to manage ventilation in patients with these already damaged structures like you see in ARDS. The goal is to avoid underventilating, because if we do that, then we have alveolar collapse, atelectasis, and then each time we try to reopen them, that causes some stress. We also don't want to overdistend them, because that can cause injury of another kind, where we have overdistension, fractures, and then pneumothorax. So the goal is to, what we're really looking to do is ventilate people within this safe zone, the sweet zone of ventilation, where they are no longer having atelectasis, but we're not overventilating them. We learned 20 years ago that one way to do that is to use low tidal volumes. This was the really seminal study that looked at ventilating people with 6 mLs per kilogram versus 12, and it showed a very significant mortality benefit. And that has really led to the core principles behind lung protective ventilation. Lung protective ventilation involves using low tidal volumes, and we still to this day target about 6 mLs per kilo, although we think that probably sometimes less is even better. If we are really having trouble, we can push it up to about 8 mLs per kilo, but we do think that the lungs will heal better with lower tidal volumes and lower pressures. So as we talked about in the last talk, if we target a volume, we also still have to be mindful that the pressure is still relevant here. And we want to maintain low plateau pressures, less than 30, even better would be less than 25. And then we adjust our PEEP and FiO2 to maintain an arterial PO2 between 55 and 80. So there are other ways to monitor how we're doing as far as ventilation. Some people talk about driving pressure, which is the transpulmonary pressure, and actually we use plateau pressure minus PEEP as sort of the surrogate way to do it. So that's plateau minus PEEP. There's been some literature on transpulmonary pressures as measured by esophageal balloons, but the most recent study was a negative study, so it somewhat has fallen out of favor. And others have talked about a stress index, but I don't think it's necessary to go there. I just wanted to make the point that there is more than one way to manage both the pressure and the volume and try to minimize injury to the lung. I don't want to neglect, although it's a difficult topic, oxygenation. Oxygenation, we know that too much oxygen is bad, and we've known this in other circumstances and in critical care. In patients with traumatic brain injuries, for example, we learned that having high O2 saturations on admission to the ICU is actually worse in terms of outcomes than low. And since that time, we've learned that that's true for patients with ischemic strokes and even post-cardiac arrest. So it isn't necessarily the case that having more oxygen is better than having less. Oxygen toxicity is a real thing. In pulmonary, this has been talked about quite a bit lately. We know that hypoxia can be bad, but we have evolved as a species at sometimes at high altitudes where hypoxia is present in the environment, so there is an adaptive mechanism for that. But there is no correlate for hyperoxia, and therefore we probably have less ability biologically to manage it. So it's probably always bad to be hyperoxic. This has been studied many times. Up until recently, this was really the guiding principle for us, this study that was done in Italy that looked at conservative versus conventional targets of oxygen, PO2s at the higher end versus a conservative target of 94 to 98. Other studies had used lower ones that had showed a mortality benefit. This was really the best study to that point. And although it had to be stopped early for an earthquake that damaged the hospital, it almost reached its target. And it really had showed that conventional oxygen versus conservative, it looked like the conservative oxygen targets were better. That was true until just earlier this year when the liberal versus conservative oxygen therapy study for ARDS was published in the New England Journal, and it showed no difference. So using a conservative versus a more conventional strategy did not seem to matter in terms of survival at 28 days. So this topic will probably be ongoing, but at the moment I would say our usual goals of not aiming for 100% FiO2, but perhaps more 94 to 98 is still very reasonable. Well, that's lung protective ventilation and lung protective oxygenation, but there will be patients that will simply not be able to be managed the way we would like them to be. Their lungs will simply be too sick. In those cases, we have to consider other strategies. So we talked a little bit about pressure control ventilation in the last talk, and that's really one of the first strategies that we'll try to use, because if somebody, particularly if they're hypoxic, and we're having trouble oxygenating them with conventional management, then going to pressure control ventilation and lengthening the inspiratory time to allow for gas exchange to occur sometimes is all you need to do. There is also a mode of ventilation called airway pressure release ventilation that has its advocates, and follows a similar principle of keeping inspiratory phase much longer and allowing for a very short expiratory phase. It's almost like the pressure control on steroids, and I'll show you what that looks like in a minute. There has been literature in the past about using high-frequency oscillation, but there were 2 studies published in the New England Journal that really showed either worse or no better benefit, and so they've really pretty much fallen out of favor. Prone ventilation has become part of the armamentarium, and you've probably heard quite a bit of that with the pandemic because it's used quite liberally for patients with COVID-19. Even prone ventilation for people who are not mechanically ventilated was being advocated for some time. So that's really become a fairly standard recommendation based on a very well-done study. Paralytics is a bit more of a question mark. There was one very well-performed study that led to us offering paralytics for these sorts of refractory patients as a fairly standard approach, and then a more recent one that was a negative trial. So I think we're left somewhat uncertain about the role of paralytics. Again, though, we use them when we have no other choice and patients are not doing well on conventional ventilation, particularly if we can't get them synchronous with mechanical support. And then there's ECMO, and you did hear a bit about that from Dr. Desai in the last talk as well, and that has become perhaps a more and more accepted method for these refractory patients. Just a very quick word about airway pressure release. Ventilation is essentially like thinking of CPAP, continuous positive airway pressure. So you have this extended period of positive pressure in the chest, and then a very brief release so that CO2 can be removed, and then another long period of inspiratory pressure. And one advantage to doing it this way is that patients can spontaneously breathe. So if they have this air in their chest like CPAP, they can still take higher tidal volumes for better or worse. The better being that they can be more comfortable. The worse being that they may take very big breaths, and that runs counter to the objectives of lung protective ventilation. But airway pressure release ventilation does have its advocates without necessarily the data. I did mention that prone positioning is something that we do fairly conventionally. That's really because of this seminal trial that was done and published several years ago showing a mortality benefit. And I should say that there were trials that had been done previously that were just simply not as big or as well powered to show the benefit, but that also had suggested a trend towards a mortality benefit. So this was just really the icing on the cake that it really does work. So prone ventilation is something that we use for people with refractory hypoxemia. It's usually done for periods of about 16 hours, and then they're put supine again. And this is done repetitively until they begin to recover if necessary. And then there's ECMO, extracorporeal life support, or extracorporeal membrane oxygenation. It's prolonged cardiopulmonary support, as Dr. Desai was talking about. It's really a way of delivering sufficient oxygenated blood when the lungs are failing. It's even more efficient at removing carbon dioxide. So for people with hypercarbic respiratory failure, it's probably even more efficient. And it looks something like this. You have gas, which is really mostly 100% oxygen, being piped through an oxygenator. And that gas is separated by a membrane that allows for gas diffusion. And then that membrane is bathed with blood. So that looks something like this. You have hollow tubes where the gas goes through and the blood bathes it so that gas can diffuse. If that looks familiar, it's because that's how our lungs work. We have a diffusible membrane we call an alveolar capillary membrane. We have blood, and then we have carbon dioxide heading into the alveoli to be exhaled and oxygen in. It's really for people with respiratory failure. Dr. Desai talked about veno-arterial ECMO for patients in cardiogenic shock. Patients with respiratory failure almost exclusively will be on veno-venous ECMO, which is where blood is removed from a vein and returned to a vein. So it's for hypoxic respiratory failure, hypercarbic respiratory failure, and it's used as a bridge to transplant. The most recent trial was by far the best done, and ECMO's been around since the 1970s, but this study that was published in 2018 is really the one that will be now quoted, and really is by far the one that most people will refer to, where it showed, strictly speaking, it was a negative trial. This did not meet its statistical endpoint, but it was stopped early. And I think many people have interpreted this trial to be a positive trial despite the negative outcome statistically, and have used this to in support of using ECMO for ARDS. So there'll be more to follow, but by far that was the most impactful study that's been done to date. So to sum it up somewhat, ARDS, we talked about the definitions. The criteria for mild, moderate, and severe has to do with the PaO2 to FiO2 ratio. I just wanted to put this slide up because ARDS management is not just all about how we manage the ventilator. There's also early mobilization, which is an essential piece of critical care management now. We want to try to get people moving, whether it's in bed or out of bed if possible, regardless of how sick they may be. Not quite regardless, but even if they're on just a little bit of vasopressor or on mechanical ventilation, they can still be mobilized and exercised. That's part of the new pain, agitation, and delirium guidelines. Nutrition is always important, and so I certainly didn't want to neglect mentioning it because it's a key part of how we help our patients. We want to minimize transfusion products because that can further injure the lungs and outcomes can be affected. And then similarly, sedation. Our sedation goals these days are light sedation. We want to keep people as awake as possible, but certainly calm and synchronous with mechanical ventilation. And so I didn't want to neglect some of the core parts of how we manage these patients. It's not strictly about mechanical ventilation, although obviously that's what I wanted to talk about. So let's move to these, just a couple of questions. This is a 65-year-old man with COPD brought to the emergency room with dyspnea, and his breathing looks labored, but he's hemodynamically stable and he's conscious. His arterial blood gas on 2 liters per minute is 7.3. His PCO2 is 50 and his PO2 is 70. You should A, intubate him, B, try high flow nasal cannula, C, try non-invasive ventilation first, D, don't do anything until you can identify his healthcare proxy to discuss prior wishes, and E, remove his oxygen because it could be contributing to his CO2 retention. Well, I think you guys get it, that non-invasive ventilation is really a good choice for this person. Now, some of these other answers are certainly interesting. Removing his oxygen might help, but this is somebody with labored breathing. So really he should be managed with a device that can assist his struggling. And that really is non-invasive ventilation. And we talked about how COPD flares are one of the main indications for using non-invasive ventilation. Obviously, finding out what his prior wishes are should be important, but it wouldn't necessarily deter you from applying appropriate therapy first. I don't think he needs to be intubated, although he may get to that point quickly. And I would reiterate the idea that even if you try non-invasive ventilation, you have to reassess at frequent intervals. And that's a very important principle here. But it certainly is the first thing that I would try to do for this patient. And the second question is, that same patient in question 1 deteriorated and was found to be an ARDS 24 hours later. He was intubated and supported on mechanical ventilation. The next day, despite strict adherence to the principles of lung protective ventilation with low tidal volume and plateau pressure, he worsened and he required high FiO2 for hypoxemia. Which of the following is not true? His worsening could be due to worsening ARDS. B, his worsening could be due to a complication of mechanical ventilation. C, he could be considered for prone ventilation. D, he is at risk for a pulmonary embolism, even if he's on prophylaxis. Or E, VA ECMO would be a reasonable next step. And I think I made the mistake of advancing the slide a little bit, but I'll give you a moment to think about it. So again, in the interest of time, I would say that the correct answer is E, and that's because his worsening certainly could be due to worsening ARDS. It can advance within 24 hours. His worsening could be due to the way we mechanically ventilate somebody, that he could certainly be have worsening ARDS even just from mechanical ventilation if we're not careful. He absolutely could be considered for prone ventilation, which has shown mortality benefit. He is definitely at risk for PEs, although we'd like to think that prophylaxis helps mitigate that. VA ECMO would not be what we would do for a person with respiratory failure. VV ECMO is what we use for respiratory failure. VA ECMO is for people with cardiogenic shock. So I think maybe in just the 2 minutes or so I have left, I will take a question or two from the chat. Yeah.
Do you want me to ask your questions?
If you'd like.
Yeah. These, I'm happy to. You can take a little breather. You've been talking for a while. Fantastic double talks here, and so relevant to what's going on, and very, very helpful. Thank you so much. One question is, in unventilated patients with diffuse infiltrates, such as COVID, is there any benefit to lateral positioning, or is prone positioning alone recommended?
Yeah, it's a really good question. And prone ventilation has had an awful lot of chatter. That is, but I've never heard of whether lateral ventilation would offer the same advantage. Prone ventilation has been shown by imaging studies and various types of ultrasounds and such to actually improve ventilation and perfusion matching. And it does change certain dynamics within the lungs. There was a very recent study, I wish I had had the ability to show you the pictures, that really highlights just how different ventilation can look in people prone versus supine. But it's so recent, it actually came up after I submitted these slides. But I've never heard yet of whether lateral ventilation works. But a lot of the chatter around the pandemic was whether people who are not yet mechanically ventilated would benefit as well. And there were certainly lots of interesting anecdotes. Still waiting to see the data, though.
Okay, thank you. Another question is, what is the difference between AVAP, AVAP, and BiPAP, and how to use it?
Well, BiPAP is really more the standard, and I think AVAP is probably an auto-titratable device. But BiPAP is what we use more typically in critical care, where you set two pressures, essentially, a high pressure and a low pressure. The low pressure you can think of as PEEP. It's positive end expiratory pressure. And the higher pressure you can almost think of as pressure support, where it supports the person's inspiratory effort. So we start maybe at 10 or 15 centimeters of pressure, and then you set the lower pressure, let's say at 5, so that they don't fully exhale and maintain some alveolar recruitment. So it's really a non-invasive way of you can think of it almost like a pressure support with PEEP.
Great.
Yep.
Okay, and I think maybe we have time for one more. Does the patient have to be intubated for the PaO2 over FiO2 to be useful?
Yeah, great question. It's really where the data comes from. And the problem is, if you're not intubated, it's a little hard to know what the FiO2 actually is. Because if you have a nasal cannula or even BiPAP on, there's still entrainment. And so it's hard to know exactly what the true FiO2 is. So really the literature is primarily based on invasive ventilation, where we have a much greater control, because the FiO2 is controlled and it only has one place to go without entrainment.
Perfect.